Assalamu alaikum warahmatullahi wabarakatuh. And then good afternoon. And thank you so much for giving some opportunity to deliver and share some of my experiences working in clinical trials with future researchers, practitioners, and then public health expertise. All right. Well, we'll start. I need to acknowledge something like this is going to be an overview. Actually, clinical trials or randomized control trials is a huge area covering entire clinical trial, data management is not like 2-3 hours kind of lecture. It's like days of lectures, right? So what I'm trying to do today is I'm trying to give some overview, some kind of taste. You might know already, you might study clinical trials, but my approach more on practical aspect of or operational aspect of clinical trials and then managing the clinical trials. So I've been conducting clinical trials last 15 years, mainly phase 2 and phase 3 trials. And so I'm actively involved, like recruiting thousands of patients in many countries. So I will be talking more on practical issues and practical or logistics and then operational side of clinical trials rather than theory, but of course with some theory with that. And I know this is afternoon. We had a very delicious lunch, right? And so of course, as a human, we may feel just drowsy, but we can help each other by, you know, change this one into more interactive session. So what I need from you, you need to be more interactive. You should ask more questions. And then I'm not expecting you are like undergrads. Now you're postgrad or further ahead. So you can interact and you can interrupt me and then ask questions. So that everybody can be like active. And then, yeah, you can get something from me. And also, to make more interactive, I have some souvenirs from all the way from Australia. So I will be in between. I'll be asking questions. Whoever answer those questions, you'll get very nice souvenirs from Australia. Okay. All right. So these are the few things I'm going to cover today. And also, please, if I go very fast, if you can't understand, or if you can raise your hand and say, hold on, slow down, so I can slow down, right? Yeah. So what is clinical research? That's all we know. The clinical research is a kind of research we do in human, right? So, for example, before starting any sort of clinical trials, we do preclinical studies. It can be in vitro or animal studies. And then when we come to the human, where we call it like clinical research, right? So when human subjects is involved, then we call it clinical research. Is that? Then clinical research can be, mechanism of pathophysiology or evaluation therapeutic interventions like medication or new medications. Also, it's not necessary to be a new medication, maybe reducing the duration of the treatment or maybe combining few medication together as a strong medication. It can be many ways. It's not necessary to be a new medication, right? And then prognostic research or outcome studies or even behavior studies can be clinical studies as far as which are experimental in nature and conducted in human. Is that clear? Clinical research, right? So two things should be experimental in nature, should be conducted in human. So as far as these criteria are met, then we call it clinical research. And then not necessary to be assess the new medication, but many other ways we can assess effectiveness of clinical intervention by putting this one into clinical research. So what is human? So whatever the research we do in live human is a human, right? So living individuals whom investigation is done, this is a human subjects. Right, come to clinical trials. So clinical studies, and then from clinical study we are going to talk about now clinical trials. So any form of experiment which involves patients and designed to elucidate the most appropriate treatment of future patients with a given medical condition. So it can be this is the definition from 1984, but it can be modified now. But whatever, clinical trials mean an experiment now. Before we said a research, clinical study is an experiment involve the patient and designed to elucidate the most appropriate treatment of future patients. So by doing trial, we are trying to get the best treatment out of the trial, that is called clinical trial according to this definition. So in the clinical trials, always we need three main categories or main parts. One is comparator or comparative trial, and randomization and blinding. So my question is, why we need comparison? Why we, for example, now I will put into a new as a scenario, like I have a new medicine now that can be treated or shown in animal studies and in vitro studies, which is very effective to treating TB, for example. Now, I want to do a clinical trials. To do clinical trials, I need three things. One is I should have a comparative arm or comparator. I should have randomization process, and also should have some kind of blinding, right? So my question is, why we need a comparator or compare this new medicine with something else? Or why I need a control? Or can I do a trial without a control? Do you get my question? So three things I need to conduct a clinical trial. Number one, a comparator. I should have a comparator arm or control arm. Why I need a control arm? To invent or to investigate a new medicine to treat, for example, TB.
Silahkan sejawat sekalian, siapa tahu ada yang mau menjawab. Mungkin bisa keluar itu oleh-olehnya. Mungkin bisa disebutkan nama, asal prodi. Ya.
Good afternoon, sir. My name is Najla from Obstetric and Gynecology Department. I think we need comparison in RCT. It's because to minimize bias, comparison helps detect and control for biases, and it ensures that both groups are treated similarly, except for the intervention being studied. Like that.
Thank you. Exactly. Yes.
Thank you, sir. Thank you, Doc.
All right. Yes, exactly. So we must need a control arm. And what will happen? Our intervention, our control. All the things will be similar in both arms, intervention and control, but except the new drug. So intervention arm or investigational arm, the participants or subjects will receive the intervention, others may not, maybe placebo or maybe standard of care, but all other criteria are similar. So to that purpose, we need a control arm so that we can measure the effectiveness of the medication with a similar group of two group of people or patients, but one group will have this intervention, other group will not. So comparator is always important in the clinical trials to see the effectiveness. Very simple way. If you say my drug is better than that, we have to compare with something else. So that is a comparator. But the comparator always remain identical with both. Group of people, same group of people, but one group will receive the intervention, the other group no. That they will receive a standard of care or placebo or anything, something like that, right? And then blinding. Then of course we need to randomize. So then only we can have like a proper trial, because randomly if you allocate the treatment without any bias, so randomization is main purpose of randomization is to, as you mentioned, like minimize the bias, right? So randomly allocating the people with a similar condition, everything is similar, then we randomly allocating, okay, this group will get the intervention or new drug, the other group no, right? And then third thing is blinding. So blinding can be double blinded or triple blinded in some cases, or maybe no blinding. Some studies we can't do a blinding. So some cases we can do double blinding. Some cases we can do triple or triple blinding. So now my question is, if study with a triple blind study, who are the people will be blinded about this interventional product? If it is an interventional, if it is a blinded, triple blinded, who are the potential people are blinded in the study? Yes.
Hello, sir. Thank you for the opportunity. The first one is the participants. The second one is the researchers. And the other one is data manager or someone that give the interventions.
Exactly. Well done.
Thank you.
So yeah, so blinding is important. Why? Mostly like if double blinded, investigators and patients or participants will be blinded. If triple, investigators, participant or patients, and then data analysts who analyze the data will be blinded. Why? If I say I'm a researcher, I have spent maybe 5-10 years to develop a new medicine. I'm very passionate about my medicine, right? Then when I give to a patient, I always think this should work, right? And then I tend to do more, try to only see, but because maybe purposely or maybe intentionally, because I'm very excited to see effect of my drug. So I will see the positive sign only. Or maybe I dig more into the patient, see the good things than negative side of this. So investigate. If I'm blinded, I don't know who is getting this drug, this person or the other person. So that is minimize the bias. Second, patients. Maybe psychological effect. Also, patient may think, if I get a placebo, or maybe this will not work. So that make them like, not compliance to the treatment or some other things. Also, the psychological effect may impact the outcome, right? Third, data analysis. Data manipulation is always there. So we can manipulate data in many ways. So if data analysts, they know this is the group of people who received the medication or intervention, the other group did not, then they can like try level best to do some manipulation, do something, this and that, and analyze the data such a way to show, okay, this will work. To avoid all these kind of bias, we should have blinding. if possible. Some cases we can't do blinding, but some other cases we can do. But only thing, so some trials it's hard to do blinding, but any trial, but one group of people can be blinded. Who is that group out of these three? Normally, blinding is the ideal, three parties, triple blind, but sometimes two groups cannot be blinded for some reason, but one group of people can always be blinded. Who is that third group? Without any problem, they can be blinded in the study. Who is that group in a clinical trial? So if triple blinded 1, 2, 3 groups, out of these three, one can be blinded all the time, but other two may not be all the time. So I'm asking the third, the one group who can be blinded all the time, who is that group of people in the study? Yes, participant. Okay, any other different answers? Good try.
Outcome.
Data analyst, you mean?
Yes, data
Yeah,
analyst.
those whoever analyze the data, they can be blinded. No reason, because sometimes participant cannot be blinded because, for example, the drug or maybe intervention, cannot be masked. So, for example, we do a study, clinical trial, TB preventive therapy with a standard of care drugs, right? So a lot of drug we give to patients, and then also another drug we are using to minimize the care from 4 months to 6 weeks. But drugs are a lot. We can't blind because obviously they can see the drug because we can't change. It's a very costly things for us to change for 3,000 people, drugs color and then identical. So sometimes we can't blind the patients and investigator, but still we can blind our third party who is data analyst. All right, very good. Sorry, who is that? All right. So RCT is an ideal epidemiological study or robust kind of a study to investigate effectiveness of an intervention. So no doubt, as compared to all other epidemiological studies, RCT is the ideal one which we have currently, right? So we discuss all these things. So this is ideal because of these reasons, right? Then clinical trials can be done in different ways. I mean, different stages, phase 1, phase 2, and phase 3, as well as phase 4. So normally in phase 1, what we measure safety, tolerance, assess the tolerance and maximum tolerable dose, PK/PD, pharmacokinetics and dynamics, estimate activity and normal in normal volunteers. Always we will have small number of healthy volunteers, very small number, and then we assess all these things in the phase 1. So phase 1 is started immediately in preclinical studies, maybe animal models, and the phase 1. And then we come to phase 2. Phase 2 is still a small group of people. We do the things and we assess the safety and efficacy here. Also estimate the drug activity and target indications and estimate the serious toxicities and all. But it's still phase 2 we do with the patients. Phase 1 is the volunteers or healthy volunteers. Phase 2 is with patients, small number of patients. And then phase 3 is the main part of our clinical trial progress. The phase 2 is a kind of real study we do to see the effectiveness of an intervention by doing a randomized control trial. Sometimes we can still do randomized trial with the phase 2, but mostly we may not, or we may, but phase 3, of course, a randomized control trial with a either control with a placebo or with a standard of care or with standard care and placebo or anything like that. And then phase 4. What is phase 4? When we do the phase 4? When we do the phase 4, why we need to do the phase 4? So phase 1, you know, phase 2, no, phase 3, you know. Then when we do phase 4, why we do phase 4? Can you tell me another word for phase 4 study? What we call it, phase 4 studies. By phase 3, the drug is evaluated and we say this is effective, and then it will be available in the market after phase 3, right? So phase 4, what we call another word for phase 4 studies. Yeah, sorry.
Thank you for the opportunity, Doctor. I'm not sure if I'm correct, but is it post-marketing surveillance?
Excellent. Absolutely correct. Well done.
Thank you.
Okay. In the post-marketing study, I can ask the other question as well. Why we need post-marketing study or phase 4 studies?
Basically, because it's already released to the community. Maybe it's more to evaluate long-term safetiness, and yeah, I think it's more related to long-term, because in the phase 3, it's already like being confirmed it's safe to distribute, but we also need to know for the long-term consequences from that drug.
Excellent. Yes.
Thank you.
Well done. Yeah. So the limitation of phase 3 is we do the phase 3, but always phase 3, most of the time we can call like laboratory skill. Though we do with the thousands of patients, there are some, you know, condition because it's a study. We spend a lot of money, like millions of dollars we spend to do phase 3 studies. So we can't do the follow-up maybe 10 years, 20 years, 30 years because it is not feasible. So we mainly, like, for example, I'm working on TB. So TB trials, we do follow up to 2 years. But sometimes we don't know after 2 years what will happen. For example, a young woman taking the TB medications, maybe after 2 years, we don't know whether, you know, maybe some, you know, that lady become infertile. So we don't know. We are not assessing at that moment, but after some time, maybe it may impact the, you know, fertility of the woman, right? So we don't know. So those things maybe can be assessed if we do the phase 4 trials. But in the past, when they like developing maybe 20, 30 years back, the studies were like completed by phase 3. But then later on realized because of these new drugs, there are so many effects happening after 2, 3, 5, 10 years back after marketed. So now it's kind of compulsory, even though very effective, very safe, everything is done with the phase 3, but still we need to check long-term effect of a drug or any intervention. That is we call phase 4 or post-marketing study. Well done. Right, so this is a quick summary. Phase 1, phase 2, phase 3, and then duration, and then size of the participants or subjects. So why I did not put the number here? A sample. I said large sample. Why I did not mention maybe 1,000, 3,000, or more than 5,000, 10,000? So I have done studies, one phase 3 study with 16,000 patients. Another study we are currently doing with 3,600 patients. So why I did not put a number in phase 3 studies, like maybe 3,000 patients or more or less? Can I put a number there? Can I define? Okay, phase 3 should be done with 3,000 patients. Phase 3 should be done maybe 2,000, 1,000, or less than 1,000, more than 1,000. Can I put a number? Yes or no? And then why? Yes, did you get my question? I'm asking whether phase 3 studies is always we know large number of patients, real patients we randomize, but I'm asking in general, can I say phase 3 study should have 3,000 patients? Can I put a number or I can't put? If I can't, why?
Ya, ya, jadi pertanyaannya untuk phase 3 kira-kira ada jumlah tertentu nggak yang perlu ditetapkan di awal? Jika iya, kenapa? Jika tidak, itu juga kenapa? Silahkan, mungkin ada yang mau mencoba menjawab. Nggak apa-apa salah, kan sama-sama belajar. Silahkan, sejawat sekalian. Ya, jumlah partisipannya.
Of course, large number, but I'm asking in the presentation or something like that, can I put a number? Okay, phase 3 should be 3,000 patients or not. I didn't put here, so I'm asking why I did not put there. Yeah, I mean, I cannot define, okay, I would say, I cannot define phase 3 trial should be this much number. I should not define. Why? That's why I didn't put, I said large number, but I can't say a 3,000 phase 3 or more than 3,000 or less than 1,000 or more than 1,000. I can't put a number. Why?
Gimana? Jadi kenapa nggak bisa ditetapkan angka tertentu pada tahap 3 ini? Yes, kan.
Or we don't know numbers of failure and relapse. We don't know the sample the number of failure and relapse in our research like that.
Okay. Anything else you need to add to that? We don't know relapse cases or lost to follow-up cases. So and anything else to add to that? Yeah. Yes, exactly. Yep, yep. So we can't define like generalized phase 3 trials should have this much patient. Some situation phase 3 can be like 10,000 patients. In some other studies, maybe 1,000 patients. In some others, say 3,000 patients. Depend on power and sample size calculation. The power and sample size calculation based on so many other criteria. What is the effect size? What is probability? And what is alpha 1 of error, type 1 error, type 2 error? So based on those preliminary data of that disease, which we are working on or which we are trying to cure. So based on that, and also as she said, some other factors including incidence of that or prevalence and incidence of that particular condition or disease, based on all these factors, we have to calculate through power and sample size calculation number of samples we need in phase 3. So it is not like a common number. We can say phase 3 should be 3,000, 1,000, 2,000. No, it is based on all other criteria which will contribute towards proper power and sample size calculation. I hope you understand. Is that clear? All right.
Ya, jadi apa untuk terkait sama clinical phase 3 ini memang dari predeterminnya agak tricky ya. Jadi karena sangat bergantung pada antara lain power sama sample size population dan juga ada beragam aspek yang kemudian menentukan, sehingga di sini dituliskan secara umum ya. Tapi tidak kemudian di predetermine precise-nya itu berapa karena tadi bergantung pada power dan sample size population. Nah, terkait ini kan tadi dipersilahkan oleh Dr. Shukry kalau misalnya ada yang belum paham bisa langsung bertanya gitu. Jadi nggak menunggu di akhir sesi. Jadi terkait sama yang phase 3 ini, kalau ada yang mau ditanyakan silahkan. Kalau ada yang masih dibingungkan sebelum lanjut ke slide berikutnya, ada? Oke, ya.
Right. So slide is like a very basic summary or simple way of explaining a randomized control trial. So here we have our subjects, and then we should have our set of inclusion and exclusion criteria. Based on the inclusion and exclusion criteria or eligibility criteria in general, we select the patients. Once we identify these patients are eligible to be in the study, then we randomize to either experimental arm or intervention group, and then control arm or control group. Then maybe outcome will be disease, no disease, or for example, if it TB, cure, no cure, and then control group, cure or no cure of TB disease, something like whatever you study. So this is simplest way of explaining a randomized control trial, but it can be very complex too. Then based on that, we will outcome like disease and no disease, no disease in both group, and we compare these things among these two groups. All right, it's very basic way of explaining a randomized control trial. So as I said earlier, also one of you mentioned, the randomized control trial has a lot of advantages as compared to all other epidemiological studies. Number one is it's all random, and both treatment and control group should be similar. Both are similar groups, and then we really testing the medication. One group, both are similar, and one group is receiving an intervention, the other group is no, so that we can see every condition is controlled, and then we see the real effect of the medication or intervention. So that is an advantage or beauty of randomized control trials. And then best study design, because providing strong evidence, cause and effect. There's no any other comparative study can show the cause and effect other than randomized control trial. So it's very clear-cut study we can always do. Allows allows us like standardization of the eligibility criteria, treatment, other intervention, and outcome assessment, and also allow us the statistical method which have few inbuilt assumptions. So we can have a few different assumptions. Based on that, we can do some statistical analysis as well. All right, but there's no any study, including randomized control trial, very best, there's no any issues, because everything has negative side also. Though it's a very best study, very best kind of epidemiological method we can use, but this method also should have some sort of disadvantages. So can you tell me some of the disadvantages of randomized control trials? What are the disadvantages of randomized control trials? Some few? Yes. Can you? Yeah, it's a very costly, need a lot of resources to complete. It takes like time, human resources, money, and a lot of, I mean, simply if I say like it takes like millions of dollars if I put in the money, and then human time, resources. So it's not easy task to simply conduct a clinical trial. Need a lot of resources. So that is one challenging, right? Millions of dollars we need to conduct a proper clinical trials. Number two, what else? What else?
Silakan, ada lagi mungkin disadvantage atau keterbatasan ya, atau kekurangan dari clinical trial. Ada lagi?
Yeah.
Ya.
Maybe difficulty of participant recruitment for a rare case.
Yes, exactly. Even rare or not rare, is still recruiting the participants to a clinical trial. Also, we need thousands of patients, right? It takes time. Also, it is very hard, not easy to recruit. Well done. Thank you. Any other? Yes, keep talking. Any catch? Yes.
Ethical limitation.
Yes, ethical limitation. Well done. Still. So yes, we can't simply do clinical trials. Some trials are unethical for us to do, right? For example, if you do a study, which cannot be controlled, is proven medication. For example, like your doctors and this, when atropine was invented, it was it came to market without randomized control trial because atropine is desperately needed medication. So it was not randomized not to give the atropine. So it came to market. So some situations we may not control. We are not able to randomize and not to give the medication because of ethical issues. Also some ethical issues, some medications we cannot test at all. So that there are so many ethical issues when we dealing with the clinical trials. What else?
Yes, I think ada yang menjawab ya tadi yang tadi disebut. Jadi kayaknya mau jawab tapi nggak jadi. Gitu.
Maybe it takes a long time and high cost.
Yeah, the time consuming again. It takes many years. For example, at least 10 years or more. Or yes, it takes a lot of time. What else? Okay, if I put into like something context, like still those clinical trials, phase 3 trials, they are very robust and all these things, but still I can call it like a laboratory condition. It is not a real world condition yet. Still we are checking the effectiveness or efficacy of the drug in a laboratory condition. So how can you explain that one? Why we still call it like a laboratory condition with some, some limitations without like saying it is like not like openly doing. We have some conditions when we do phase 3 trials. What are the laboratory conditions we call it, like, or how we explain that one?
Can you repeat that again?
Okay, phase 3 trials, when we do, though it's very good trial, very good study, but still we call it like we conduct phase 3 trials as a laboratory conditions, not open, because we need to have those limitations or conditions. Why? For example, when we are doing a clinical trials with the new medications, we can't like openly give to anyone. It's a kind of, we call it like laboratory condition. We artificially make some, inclusion, exclusion criteria so that it cannot be given to everyone. So why is that?
Jadi pertanyaannya, kenapa pada level 3 condition tuh seperti artificial laboratory gitu. Jadi cukup tertutup terus nggak kemudian siapa aja itu bisa diberikan. Jadi dengan kondisi dengan phase 3 clinical trial tersebut itu kan kenapa ada kayak restriksi, jadi nggak kemudian eh, apa namanya perlu kemudian apa obat yang kemudian diintervensikan itu ya diberikan begitu aja.
Why is that?
Ya. Jadi kayak apa rigid gitu ya. Itu kenapa kira-kira?
Okay. Anybody has any answer?
Iya, nggak apa-apa. Silahkan. Iya, ini juga kalau misalnya ada ide terus pakai bahasa Indonesia nggak apa-apa, nanti kita bantu terjemahkan. Silahkan.
Mungkin untuk memastikan bahwa efek itu benar-benar dari RCT-nya, bukan efek lain. Jadi harus terkontrol ketat agar bisa dibedakan ini karena perlakuan atau bukan gitu.
Why it's strict is because to make sure that the effect that is obtained is due to the intervention and not due to other aspects.
Yes. Yeah, that is, we rather call it like randomization or something. So we randomize to see, randomly allocate the participants to see real effect compared to our control. Yeah, my question is like, still we randomize, we do everything, but still we are not open to give to anybody. We have kind of restriction or eligibility criteria we maintain. For example, I'll put my own trial. Now we do a TB preventive therapy. We do a TB preventive therapy with new intervention, that is rifampicin. We want to reduce the TB preventive therapy from 4 months to 6 weeks, as compared to 4 months therapy with rifampicin. We give 600 milligram of rifampicin every day for 4 months as a TB preventive therapy. Now our new drug is rifampicin, 600 milligram daily for 6 weeks. But we select the patients who has no any other comorbidities. For example, liver problems, HIV/AIDS, or lung problems, other lung problems, cancer. So these are excluded from our study. So we are testing kind of people without any other problem, but only TB. So that is like a laboratory condition. But when the drug is, after this trial, when drug is like proven is effective, then it will go to market. But it was tested in the laboratory condition because we did not try, because in the real world life, people with a TB or TB pathogen in the body or latent TB patient may have so many other health conditions, comorbidities. But when we are really trying this medication as a clinical trial, phase 3 trial, we exclude those comorbidities to see our, because we don't want to get in trouble with kind of comorbidity. Most of the time, we exclude those people with other health condition. Also, we exclude people with pregnant mothers, lactating mothers, also children under 12. So these are the like exclusion, so that we are refining our population into a laboratory condition without any other health issues or vulnerabilities, so that we are testing only on the set of people with no any other problem. So that is that's why I'm calling it a laboratory condition, not the open condition. But in real life, it is not the case.
I get this correct, hopefully. Maybe later Dr. Asri can jump in. Okay, so jadi yang tadi ditanya balik ke yang fase 3 itu kan seolah kayak laboratory setting, dalam artian misalnya tadi dikasih contoh dalam penelitiannya beliau terkait dengan TB, itu benar-benar pada fase 3 ini hanya pasien yang dengan kondisi atau diagnosis TB. Semua yang ada komorbid ya, misalnya komorbid pasien TB dengan komorbid yang lain dan juga ibu hamil, itu dieksklusikan. Jadi hanya pasien TB tanpa komorbid. Nah, itu yang maksudnya adalah seperti maksudnya laboratory condition karena pada fase 3 ini. berbeda pada misalnya kok pada akhirnya nanti kalau obat ini itu dipasarkan itu kan tentunya akan lebih luas ya. Maksudnya orang dengan berbagai komorbid itu kan juga akan kemungkinan menggunakan obat ini. Tapi pada fase 3 itu sangat rigid dan sangat dikontrol siapa yang kemudian pasien yang dilibatkan dalam clinical trial fase 3 ini. Jadi dengan contohnya beliau itu yang dengan obat yang dikembangkan itu misalnya untuk pasien TB tapi hanya yang pasien yang hanya dengan TB tanpa adanya komorbid apapun. Nah, itu kan kayak direkayasa supaya ya udah kondisinya seperti itu walaupun mungkin pada kenyataannya nantinya ya yang akan menggunakan itu bisa di kondisi yang nyata kan dengan beragam keadaan atau komorbid. Do you have an additional follow-up question for them?
No, that's the reason I wanted to explain. I hope they understood that.
Yeah. Do you want to simplify, Dr. Astri, or is there anything else? Okay. Yep. So,
Any question?
terkait ini mungkin ada pertanyaan?
Or any concern or any question? Any comment on that? Or laboratory condition, or we call it artificial, not real.
Yang benar-benar sudah direkayasa atau diatur atau laboratory kondisi dalam terminologi yang digunakan oleh Dr. Shukry. Ada satu pertanyaan, silakan.
Ya dokter. When we do the limitations, when we check the like comorbid itu dok, the comorbid when we check the comorbid after phase 3 or on the phase 3 karena kan we have to check that comorbid again before we go to the phase 4 gitu dok.
Yes, it's a very, very good question, right? So normally, now I will give the same example here. First, we have started our study, TB preventive therapy, and then we exclude all other chronic conditions and comorbidities, not mild one, the serious one like liver damage, cancer, or heart diseases, all those things, right? And then after that, there are two ways. Number one, then based on the literature, we know the medicine. Based on the literature, we support that based on literature, it is safe to use, but we put up precautions. It is not tested on these conditions. Then it is marketed. Number one. Do you understand what I mean? Number two, now what we do, we have been running this trial now for 3 years. Now we revise the protocol. So far it is safe for adult, normal human, normal adults, female, male. Now we are adding slowly children 12 and above. So far we have been doing this one for 18 and above, now 12 and above. Now also we are adding now pregnant mothers to the study after 3 years. Then we'll test few more years and then we keep adding. That is the second way, but normally second way is not feasible for a clinical trial, but if we do like that, adding new comorbidities, it will take forever. It won't finish. So what we normally do, the first way, we try in the normal people without any other health conditions or other critical health condition, and then we support with the literature and then put a code. This is tested only patient with a TB symptom or TB, these things, not other comorbidities. And then after that, it is called for like clinicians to decide or try with other pregnant mothers, and if anything happen, closely monitor and then accordingly need to react. But the second way is we can keep adding. If safe with a normal adult, then we can add other people and other comorbidities. But normally we don't do. Sometimes we do only the pregnant mothers and then children, and that's it. Otherwise, it will like lifelong clinical trial. So it is not practically possible. Is that clear? All right.
Sudah jelas ya. Jadi untuk yang tadi kan pertanyaannya terus kapan kemudian diuji cobakan dengan beragam kondisi komorbid. Dari pernyataan Dr. Shukry bahwa memang pada saat selesai fasenya itu nanti dilakukan publikasi dan memang didisklaim bahwa obat tersebut itu pada saat clinical trial itu adalah pada kondisi yang mana dan tidak pada kondisi yang mana. Nah, seiring dengan waktu itu dari dewasa kemudian nanti bisa diujikan lagi pada anak-anak setelah beberapa tahun, habis itu baru pada pregnant, pada ibu hamil. Nah, kalau kemudian tadi terkait dengan komorbid, karena komorbidnya banyak, ya nanti kalau memang dari penelitinya sendiri kemudian mau melakukan komorbid, ya itu nanti satu-satu, tapi ya seperti Dr. Shukry tadi sampaikan, itu akan sangat lama. Karena kan sekian banyak komorbid kan harus diteliti satu per satu. Jadi dari beliau biasanya itu dari dewasa, kemudian ke anak-anak, ke ibu hamil. But are there any like comorbid condition that has been studied for the clinical trial apart from you mentioned that for adult children and pregnant mothers, but for like comorbid
Normally
condition?
in our trials we don't,
Okay.
because every additional disease we add, we need a lot of cases. Sometime, if you recruit 1,000 patients, out of 1,000, maybe one with the lung cancer, and we can't come to a conclusion. Then if I want to add the lung cancer into the TB treatment, I need to do maybe 30 years, even 30 years, maybe I hardly get 10 patients or 20 patients. Practically, it is not possible. But though it's theoretically possible, but practically, we can't add the comorbidity unless it's very common comorbidities with this one. Yes, possible. For example, TB, with the TB, we always add the HIV, co-infection with HIV. That is possible because most of the African countries, always the TB, always comorbidity with the HIV, most of the time. So we add because we can easily get the sample.
Oke, iya. Jadi berangkat ke komorbid itu memang dilihat dulu ya mana yang paling sering, karena kayak misalnya komorbid TB dengan kanker itu juga dari pernyataan beliau bahwa bisa sampai 30 tahun karena mencari sampelnya dan standar sampelnya itu juga bukan hal yang mudah. Tapi kalau misalnya yang tadi kayak kondisi yang sering seperti TB dengan HIV itu mungkin masih memungkinkan untuk dilakukan karena kasusnya juga banyak.
Thank you. All right. So I hope you have clear idea about what is clinical trials and the phase 1, phase 2, phase 3, and then phase 4. Phase 4 trial, before jump into this, it's a trial we do it when the trial, when the drug is marketed, post-marketing study. So from that, mostly we assess, we investigate long-term effect of a new drug. For example, some drugs we don't know. We follow up maybe 2, maximum 3 years. After that, what will happen to the patient, we don't know. So as I said earlier, some patient may get like, impotency or maybe some heart diseases after 3 years, or some what we call the bone problems, osteoporosis, or maybe infertile. So these are the long-term impact of some medication. We don't know, but we can't keep the patients to follow up 3, 10, 20 years. So we stop our trial 2 to 3 years, but then post-marketing study, it's a big study. Maybe thousands of patients are recruited and they do long-term effect. They check the long-term effect of medication after marketing. So after marketing, by phase 4 study, we can also sometimes capture these all comorbidities, because once marketed, it's anymore no condition, no artificial condition. Now it's open to everyone, whether it's pregnant mother or children or anyone, or maybe with other health condition or comorbidities, they can use the medication with a care, kind of additional care. So it is kind of answering so many real life questions by phase 4 study. Is that correct?
Yeah. Dr. Shukry, sorry, you have 5 minutes more for the first topic.
Right. We will rush. I mean, this is kind of continuing. Right. So we know the randomized trial. Now we are trying to do kind of how to develop or conduct a clinical trial or phase 3 trial step by step. So this is the way of like writing the protocol as well, right? So number one, we have to define the research question for your study. That is very important. So number two, select the study design. Once the research question is formed, hypothesis generated. Based on the research question and hypothesis, we need to come up with select a study design. Which study design? It is like phase 2, phase 3, phase 4, randomized trial. Within randomized trial, what kind of randomized trial? And then determine the endpoints. What are the primary outcomes, secondary outcomes? And then estimate the sample size and power. So we need to do the power and sample size calculation to understand actually how many numbers of participants or subjects you need to evaluate this medication or this intervention. And then should have proper data management plan, also need to develop a proper timeline and budget. So these are the certain steps you need to consider when you are developing a protocol or planning a randomized control trial. Yeah, same. Sorry. Right. So we are going to start our clinical trial. So start point is there. We'll see how it goes. Right. First, we need to understand the problem. Without problem, we can't make a solution, right? So we have to have a clear understanding of what is the problem, right? So based on the problem, we will come up with our research question. So first, we start any research, any trials, any clinical trials. We start with the problem, and then try to answer the problem, right? So problem can be increase incidence of TB, because I'm TB person. I always, it comes to my mind TB, but you can do anything, like whatever your expertise. Increase, so problem is increase incidence of TB. So TB incidence is increasing. So solution, we have to find a way to decrease the incident, right? So that is a problem and solution. So by a randomized trial. So, or efficacy of non-regimen in different population. So need to check the non-medication, but efficacy not tested to one population. Also we need to do other population. For example, we have done the efficacy study or phase 3 study in adults, but not children. Then we can try in the children. That is also can be the problem. And so solution is efficacy studies in other population. Adverse effect of TB treatment. So always, you know, as a clinicians and doctors and all health professionals, TB drugs are having having a lot of side effects. So adverse effects. So how to minimize this adverse effect by maybe some other combination. And then delayed diagnosis of TB disease. So the delayed diagnosis is a problem. So how to minimize the delay? So delayed diagnosis means spread is high. So how to minimize the delay? And the cost and new regimen and diagnosis tool. So cost of new treatments and diagnosis are very high. So how we do some studies to minimize the cost. High rates of patient decision to stop early duration of treatment. Again, TB treatments are maybe 6 months. If you know, MDR TB or XDR TB up to 12 months or maybe 2 years. So that is a problem with the patients. Compliance is a problem if a long-term treatment or regimen. So high rates of patient decision to not stop early because of it's a problem to take the medication for many months. So how to minimize this one? Each of these questions need to be different design. So you can, so depends on your problem. You need to develop your questions. So all the problem will not have the same solution, same research question, right? So according to your interest, you may have your problem. Then based on the problem, you need to develop your research question. So now you know your problem. What is your problem study, research? Now you need to have a question. Based on the problem, you need to develop a question, right? Research question. And then that leads to hypothesis. So it is very, very important to have a proper right question based on your problem, right? So step one, the definition of the problem you know, and then who gets the problem. So problem is who gets the problem, that is important to know. And then how common it is a very, whether it's common, how common it is. And then does it cause death, morbidity, quality of life? So these are the things you need to consider before generating your research question. And then understanding of the biology, clinical manifestation, pathophysiology, biochemistry, and then transition is it's a kind of reflection. I can't, the color contrast is not good. But what is known from preclinical studies, make the question precise and possible. So research question is kind of a foundation for any research. Based on the problem, the correct research question, considering all these factors, is very, very important to have a correct research question. Then only you can solve the problem, solve the research question, or answer the research question appropriately. Is that clear? Right. To answer research question, we use it like PICO model. We use PICO framework or PICO model to mostly we based on the PICO model, we generate the research question. So step 4, research question again. Now you have problem, and then you need to generate the research question, but sometimes you don't know whether they have already somebody else been doing it or already done it. So you have to understand, you need to do the proper research review to understand whether this problem already resolved or already been studied. Otherwise, waste of time, waste of money, waste of resources, right? So literature review is also important. And then also sometimes it is not published, but there are, for example, I'm doing a lot of TB research. So I know who are the TB experts. I can talk to other different experts from different countries and understand, and then discuss this issue to generate my research question, so that they can give a feedback. Oh no, it's already understood, and the problem being, studied in some other part of the world, so we don't know. So it is always better to discuss with expert on that field, so that you will understand the problem is still existing. Sometimes the problem is for us, but maybe it's already resolved from other part of the world. So you don't need to bother to resolve yourself. You can get those information and then use in your context. All right. So to generate the research question, these are the set of things you need to consider first. Right. Now, this architecture of the PICO. So based on this PICO kind of thing, you need to come up with a research question. All right. So P, who is the patient population or patient or population? So when you coming up your research question based on your problem, number one, you have to understand who is the population or patient. Number two, I or E. What is the intervention or exposure you want to test to solve the problem? I is intervention or exposure. C, what is a control or comparison group you may have, right? So it not necessarily to be placebo, maybe some standard of care or some other things. So what is that? O, outcome. So considering all these together, you can develop a research question yourself, right? You have the problem, and then you study the problem, and then do all other 5-6 things to understand the problem is real problem and existing problem. No one has resolved the problem. Then come to PICO method to put all these things together to come up a proper base, proper foundation by generating a good, strong research question. Any questions so far? Or is that clear? It is very important part of the any study, especially randomized control trial, to come up the problem and the research question correctly. All right. Now, I'm just applying the PICO now into a real world or study context. For example, formulation of PICO question. INH is, isoniazid. Is isoniazid effective in preventing TB? Right? So TB is the problem. Maybe, for example, let's say in Indonesia, TB is the problem. In the world, like globally, the second highest TB incident country is Indonesia, right? So we need to resolve the problem. So we think, isoniazid is a new drug for the TB. Now, research question is isoniazid effective in preventing TB, right? So your intervention is drug, maybe isoniazid. Your outcome is TB prevention. And then problem is TB. Intervention is 6-month isoniazid. Outcome, the reduction of TB cases, and comparison is maybe standard of care. Right? So population. When you are talking about P in the PCOP, you have to consider all these factors. Population maybe specify as much as possible, whether adults and children, female, male only, or all gender, community, where you do gender, occupation, all those things should be considered in the population. And then intervention. It can be drug intervention, it can be other surgery or any other intervention, nutrition or anything else. So you need to consider, we need to specify. And then control or comparator, C. Sometimes most difficult part, because it is very important to understand which kind of ethically and then in terms of research, in terms of ethics, and in terms of ethics, how and who is the comparator. That is important. And then what they receive, placebo, nothing, standard therapy, or optimized background therapy or something like that. And then I, intervention. So purpose of intervention, why we need this intervention, dose, how much, the pharmacokinetics of that intervention, how long it should be given, pharmacodynamics, safety, right? Standardization, like delivery method, dose, formulation, duration, devices, all these things should be considered when we are developing a research question in terms of intervention. And the duration of effect, how many months you are going to give, how many weeks this treatment, how many days is based on your the problem, and then intervention, right? And then if it is devices, how long the term problem and all these things. And then outcome. So outcome can be primary outcome, and then primary is the main outcome, or from the intervention, direct outcome is a primary outcome, and also may have some secondary outcomes as well, right? So, and then primary outcome can be like, specific to, so it should be all these primary outcomes should be specified and in advance, like, this is the outcome, TB incident reduced by 30%, or reduced by this much percent. So very clear outcome should be specified, and they should be measurable also. Like, sometimes some outcomes we can't measure, then it's no point, right? So measurable outcome should be there. It's a quantitative data, and outcome should be like important, and but also relevant to the disease and intervention. Something we are investigating something, but outcome will be something else, not directly related to intervention. So that also cannot be measured. And then it can be many things, like quality of life, adverse event, or much more. So primary outcome may be one, or mostly one. Primary outcome may be only one, or maybe some kind of collection of few. For example, some cases, two co-primary outcome can be. And then also primary outcome should be measured based on the proper sample size. So the sample size is so important because of the how much common that disease in the community. Based on that, how much you need to see the outcome on difference. So that is important to consider when you are measuring or planning a primary outcome in your research question. The secondary outcome can be safety, adherence, tolerance, anything related to your problem, right? So based on all these things, now what I'm trying to summarize, we know the problem. Now you are generating your research question. Still you haven't done anything in your study, but the basic thing. You generate research question. To generate research question, you are now applying PICO framework. So one of the PICO framework is, this is like O, outcome, P, population. So when you are each part of the PICO, you have to consider all these criteria to come up with a strong, measurable, achievable research question. So now maybe you're a pharmacist or clinician, whoever you think you are working on. Now this is for you to come up with your PICO, right? So you are a pharmacist or clinician in the community clinic in Lombok. A large number of adults who visit your clinic report symptoms of more than 2 weeks of the cough, persistent cough more than 2 weeks, fatigue, mild weight loss. So the clinic recently introduced an AI-assisted chest X-ray screening tool designed to help early detection of TB. Normally, TB, we do the chest X-ray, and then if like so many patients, thousands of patients come into TB clinic or hundreds of patients, then time, every chest X-ray is screened by a doctor, it takes some time, right? So that you are introducing a new AI technology so that AI can assess the TB. But some clinicians believe that conventional sputum microscopy and gene expert testing remain the most reliable diagnostic pathway than AI-assisted TB screening or AI-assisted chest X-ray screening. Now, I just want to like discuss among yourself, two, three, whoever nearby, and then come up with your what is P, what is I, what is C, what is O for this case or for this problem. So this is your problem. You talk to your friend, your colleagues or peer close to you, and then come up what is PICO. Then based on the PICO, you need to generate your research question.
Silakan, jadi di depan ada kasus. Dari kasus yang ada ini, silakan kemudian ditentukan PICO-nya apa, dan dari PICO itu coba diusulkan pertanyaannya atau urusan masalahnya apa. Silakan, bisa didiskusikan Pak dengan temannya yang sebelah kiri dan kanannya. Silakan teman-teman sekalian. Kalau sudah ada yang ketemu, oh ya silahkan.
Yeah. For the PICO is for the population, a large number of adults, and intervention, AI-assisted chest X-ray screening tool, and the comparison is sputum microscopy and gene expert testing, and the outcome is early detection of tuberculosis.
Excellent. So in terms of P, can you repeat again P?
A large number of adults.
Okay, large number of adults. So somebody else can add something to the P? Okay.
Maybe for the P is adult with persistent cough, fatigue, and mild weight
Well done.
loss. Thank you.
What do you want to add?
Adult visiting a community clinic in Lombok with a persistent cough more than 2 weeks with fatigue and weight loss.
Thank you so much. That's the P. Well done. So I hope you understand now PICO. So based on the problem, we need to generate our, come up with our PICO. This one is very straightforward, but in real scenario, it's not like a 1 minute thing. To come up with a research question, you need at least clearly 6 months. Okay, it's not like a 1 minute thing because, as I said, P, I, O, and all these things you need to do because now I know it is like a hypothetical example, but already this study been done, right? So in real situation, you can't just come up this thing, no, because there are so many now already use AI assisted TB chest X-ray are like widely used in many countries and tested that it is very efficacious and all those things, right? Efficient. So, but for understanding the PICO, yes, straight away. But in real life, when you do your own research, you need to do all other factors. I mean, literature review, talk to your colleagues and all, whatever the things I said, you need to do all the things to come up with a PICO and question. All right? So let's see what is there. So it is not Vietnam, Indonesia. Yeah, it's just X-ray and then, right? So outcome will be diagnosis accuracy. All right. Okay. Now, you know the PICO. From PICO, you need to come up with your research question. Who can come up with a research question based on these things? So you know the problem. Now you know the PICO. Now you need to come up with your research question.
Jadi tinggal dirumuskan pertanyaannya apa? Ini ada yang sejawat yang, oh yang Pulmo yang semester awal malah kayaknya lengkap nih. Ayo silakan. Gak apa-apa dicoba. Itu kayaknya udah ngangguk-ngangguk itu. Gak apa-apa pakai bahasa Indonesia juga gak apa-apa. Nah, Dokter Ratu mau coba? Gak apa-apa Dokter Ratu.
For the research question, maybe can AI assess chest X-ray screening be used to screening for the TB diagnosis?
I need more. Because now think of you are not going to do phase 3 clinical trial. PICO is here. Based on PICO, you need to add all these things. What is your intervention? What is your control? What is your population? And what is your outcome? All together, can you put into this and come up with a question? So you are right, but partially. You need to come up with the whole, all together as a one research question. Yeah, you can try. Yeah.
Can assess checks X-ray screening used to be early diagnose in for TB for adults patient of TB compared to the standard diagnosis?
Yes, maybe 75% you have done, well done. Yeah, can you add further?
Thank you, sir. I will try to answer. Maybe in adult with the suspect TB in Lombok, does the AI assist chest X-ray screening is comparable or superior than the standard diagnose using microscope or gen expert for diagnose in early TB detection?
Great, yeah. Well done. Yeah, so so the question of that clinicians were like accuracy. He said he's doubt about accuracy. So we are testing the accuracy. So as compared to the standard gene expert and sputum microscopy, the TB, what you call AI assisted is comparatively screening is accuracy and reduce the time of TB diagnosis or early diagnosis, right? So I hope, can you now figure it out, like how the problem, and then based on the problem, you identify who has problem, population, and then what is your intervention to solve the problem, what is your control, and then outcome, right? So based on that, you come up with a research question. But remember, this is very straightforward, without any complication, just giving some kind of flavor how you do your research this way, right? But in real situation, it's not straightforward, something like that. You have to spend a lot of time reading, understanding, talking to your experts. Then only you need to come up with a research question. Okay, right, you are done with the research question now. Right, now we need to know, to do this research, what sort of experimental design you need, type of experimental design. So maybe randomized control trial, quasi-experimental, cluster randomized trial, or cross-section, crossover trial, or factorial design. Which one you prefer to do this one? So there are different methods or design available to do a trial, but you can't like randomly select any of these. You have to study properly, understand this design based on your requirements, based on your problem, based on your hypothesis. You need to select correct design. So before going to the selection of the design, I just want to know, what are these different types of design? Randomized control trials, of course, it is very common one, everybody uses, right? So we randomly allocate the people to truly randomly allocate the people to in two groups, control and random, control and intervention, and then see the effect over the time based on the study design and study type. And then quasi-experimental, what is that? The second one, is it actually kind of experimental study? Number one. Number two, is a randomization process involved in that study? In this study design, quasi-randomization, or some other word also called. I don't want to say that one until you come up with something.
Mungkin ada yang mau membantu menjelaskan untuk quasi eksperimental seperti apa? Apakah ada unsur randomized di dalamnya?
Ah, okay. So I should learn from you then. Yep.
In quasi-experimental, we give interventions, but we don't randomize.
Yes. Quasi-randomization is not, it's an experimental study. We use this study to evaluate some effect of an intervention, but we do not randomize. Excellent. Very well done. And can you tell me another name of quasi-randomization? Well, one more, the different name. Who is answering? What are the name? Any other name you can tell? You can call it like quasi-randomized as what? Okay.
Non-randomized experimental study.
Any other way? Any other term we commonly call? Sorry?
Pre-experimental design.
Pre,
Yes.
yeah, pre and post study or post experimental design. It's experimental, well done. So experimental design, but we don't randomize, but it still is experimental. So normally we do like the same population, we have pre and post. In between the random, we give the intervention and then we evaluate. So before randomization, pre-evaluation, sorry, no randomization, pre-evaluation, and then we apply or we give the intervention, and then after some time we look for the outcome, that is post-intervention evaluation, right? So there's no any randomization involved. So these are the types: random control trial, participant randomly assigned, intervention and control. So ideal method is, of course, randomized control trial, RCT. But these are the experimental studies, non-randomization or quasi-experimental. So allocation not truly random, but include pre and post. Control before and after interrupted time series. Example, training impact in 2 districts. Right. For example, I also do like small pilot studies. We do pre and post. We assess the behavior of someone, health professionals pre-intervention, and then we give the intervention. After intervention, we assess again. Because of the intervention, any changes happen, something like that. And then class randomized group. So class randomized group is different from the randomized control. Is like we have clusters instead of individuals. In the randomization, randomized control trial, we randomize the individuals. But here in the cluster randomized trial, we randomize instead of individual, the clusters. Clusters can be number of pharmacies, cluster will be villages, schools, hospitals, or something like that, group. So we randomize the groups rather than we randomize individuals. So main difference between randomized control trial and cluster randomized control trial, we randomize differently, individuals here as a group or as a cluster. There's a reason for that. And then crossover trials. So it is interesting trial. Each person receive both. In this case, a group of participants, they receive, sometime they will be controlled, or maybe if you have 2 interventions, for example, 2 devices you want to check with one group of participants, then one group will take one sort of intervention, and then a lapse period, like if we don't have any intervention, after some time they take the second type of intervention. The other group, vice versa. They take the second intervention first, and then elapse time, and then first intervention after some time. So that is crossover trial. Receive the both treatment sequentially with a washout period. The elapsed time is, we call it washout period. And then factorial trials test multiple interventions simultaneously, more than one intervention. So up to now, we have test like 1 or 2 or more than one, we call factor and intervention studies, right? So factor are more complex than randomized trial. And then cluster, little more complex than normal randomized trial. But all this achievable. But again, the simplest way is non-randomized or quasi-experiment. If you want to do a small studies, you still want to do kind of experimentally study, I would rather say you go for quasi-experimental, but based on whether it's applicable, right? So if it is possible, then you can do. It's based on your research question. So, okay, come back to the experimental design. So in Lombok province, community pharmacies often see adults with more than 2 weeks, cough more than persistent cough within more than 2 weeks, and university team wants to evaluate whether brief counseling script, training, referral card increases the completion of TB diagnostics testing compared to usual care. Right? So here the problem is community pharmacists often see the patients. Normally patient with a cough or chronic cough or persistent cough more than 2 weeks, they go to pharmacy. Community pharmacy asks for maybe medication, some medications for relieve the cough, right? So now as a university, maybe Mataram University staff want to do a study. What is study? Team of researchers want to evaluate whether brief counseling is script. So they're going to give some brief counseling script to the pharmacist, and then training how to use the script, and then referral card, some referral card to refer these cough patient with a cough, to refer them to TB clinics. So they want to check whether this increases the completion of TB diagnosis compared to usual care. Usual care, they just give cough syrup and send them home, right? Do you understand the case? Or any question, any clarity needed for the case?
Ya, gimana kasus di depan sudah jelas atau ada yang mau dikonfirmasi?
Very quick peek for this.
Silakan sama dengan sebelumnya, jadi boleh diskusi. Nanti yang sudah ketemu pikonya apa, bisa angkat tangan.
Okay, I'll come because based of the time. This is a PICO, right? So population adult with the prolonged cough in the community pharmacies, population, right? And then intervention, script, and then it's not AI assisted referral card, but referral card, okay? To patient to clinic, and then some reminder or intervention. Comparison, usual care, and then outcome, the TB diagnostics. Primary outcome is completion of TB diagnosis test, and the secondary outcome, time to test or something like that. So this is the PICO. So my purpose of this is the second one. This is the main question because already we have discussed this in detail. I want to know this one now. So for this study, for this problem, you have PICO, then you can generate your research question based on the PICO, I'm very sure. Then what could be the suitable study design based on all these experimental design we just discussed? Which one you prefer for this particular study? So my question is this.
Ya, jadi di slide sebelumnya kan sudah dijabarkan jenis-jenis studi desain. Nah sekarang dengan Pico yang sudah ada di depan, jenis study design yang sesuai, itu yang mana? Silakan tebak-tebak buah manggis. Dijawab.
That's it? No. Okay. So that's the answer. Yeah, that's it. That it's a it's a feasible, possible way of doing is quasi or pre and post trial. Yes.
Yes, Prof. Quasi experiment
Okay.
because the population is not random. Thank you.
Yes. Thank you very much. And also, yeah, population is not random. And any other reason we want to do quasi for this particular problem? Why we want to do quasi or pre and post or yeah, this design we need to use? Any reason? Any reason why we want to do quasi for this particular case or particular problem to solve the problem?
Ya, alasan lain selain aspek randomisasi tadi, yang kemudian kenapa kuasi ini sesuai dengan rumusan masalah atau piko yang ada di depan?
Yeah, we are counting the both. So any reason you say it is a quasi, it should be a quasi or possibly quasi. So one of the reasons is, yes, we don't need any randomization in this case. So it is, it can be quasi randomized trial. Any other reason for to be or considered to be quasi randomized or pre and post study? Yeah.
Because we cannot give the intervention for all of people who come to pharmacy. We can give the intervention only for people who have cough more than 2 weeks and have the symptoms.
Yes. So our study population is the pharmacists who we will be training, and then yeah, outcome is these patients. Yeah, not all the patients. That's correct, because our underlying criteria is patient with more than 2 weeks, because that is more likely to have maybe one of the reasons, one of the symptoms of TB. So we train the pharmacists to refer these patients, and also we need to consider like when we are explaining these kind of research is we clearly said like university staff. It means always poor people, like so they don't have millions of dollars to do proper randomized trial. So resources also important in terms of conducting this study. So it's a very small study. The nature of the question, nature of the case is very simple study. And then also there's no any randomization required for this one. So pre and post is the appropriate one, right? And then sample size calculation. As I said earlier, whatever the randomized control trial, it can be any design, any clinical experimental studies, we should have a proper sample size calculation, without sample size calculation, we can't randomly say we need this much people, this much patients to do the study. Unless if it is a pilot study, yes. Pilot studies are studies which are not proper studies, but to understand whether you can do this study like in a pilot version, a small group of people, to see the feasibility, acceptability, and fidelity of the study. So those pilot studies, we don't need to do any sort of sample or power calculation. But if you, based on after the pilot study, if you want to do a proper study, proper experimental study, we must have a sample size calculation. So to do sample size calculation, of course, if you are running or if you want to conduct a clinical trial or experimental study, you will not be alone. You will have a big group of people, maybe 40, 30 people with different expertise. So one of those is statistician, clinician, pharmacist, epidemiologist, pharmacoeconomist or economist, health economist, and something like that. Also clinicians, study nurses, and then operational staff. Something like any experimental study, you need to have different expertise. One cannot be doing everything. I can't do sample size calculation because it's work of statistician, right? So something like that. So a big group of people, but underlying thing you should understand, sample size calculation is required. The sample size calculation is based on many factors. Number one, objective of the research, power, variability, effect size, and then type 1 error or type 1 error, right? So based on that, normally when we do any sort of sample size calculation, we standard of power, we take is like 80%, right? Increase the power, we can control the power. So if we increase the power, the sample size will be increased. And then if we decrease the power from like 80%, 90, 95%, or 80, 70, 60, but normally every sort of studies, we keep power kind of standard level is 80%. It means this sort of whatever the samples we are getting from this power, 80% power is like a power of 80% detecting whatever the difference. Then difference is like the effect size. For example, if you look at the early example, we had checks, what do you call, referrals, the pharmacist referring the patients to the chest X-ray or diagnostics with the TB symptoms, and no diagnosis, no any sort of referral. So the effect size may be by giving this intervention, we can improve case detection or appropriate diagnosis test to these patients by maybe 30%, 40%. That effect size you can't put randomly from your own. That should be justified, or just should be your kind of pilot work should come from pilot work. As I said, a small group of people you can do, or else justified by some other researchers or some similar studies conducted in somewhere else, or you have done the similar studies, similar type of study, but with the different conditions. So that should be justified. So effect size, maybe in this study, I just put like from example, TB preventive therapy with a randomized control trial, baseline is 70% effective. Then I want to improve by intervention by up to 85%. It's been 15% increase. So by that way, we can calculate always our alpha. Normally we put 0.05, or else we can, if we want to do more precise, type 1 error, more precise, we can go for like 0.01. Then of course the sample size will increase, but normally we do 0.05, power 80%, and then according to our pilot study or literature review, we understood effect size going to be like 15% change from 70 to 85. Based on that, for this particular study, we need each arm 118. So total we need 236, right? So for this experimental study, we need sample of 236. So what I wanted to here you to understand, to do the sample size calculation, we need all these factors in advance so that we can easily apply and get it done. All right.
Sorry, Dr. Shukry, you have 10 minutes before the end of this session. Okay.
I will be. So again, data management, and then using consort. Consort is actually, we use consort to reporting the randomized trials appropriately. But to report, if you apply this consort guideline in the data management, then it is easy to report accordingly. So mostly consort guidelines are used to report the randomized control trial finding appropriate way without missing, right? So data management is important part. Each and every stage of data, from data collection, each and every part of this randomized trial should be well understood, well managed. So there are so many different ways. Data management is a different area you discuss in detail, but I just want to give some like highlight from enrollment, even pre-enrollment. From pre-enrollment screening, all the data should be recorded appropriately and managed very well by experts. All right. So pre-enrollment, screening log, randomization, consent tracking, all the data is very, very important, because when we are reporting, if we don't do this consort or proper management of the data from the beginning, when you're reporting, when you're publishing, when you're analyzing the data, it's going to be a very big problem to go back and trace these things. So you have to keep in your mind from beginning. When you start screening the patient for your study, you have to have all things recorded appropriately. So there should be some track, logs. But normally in the sophisticated way we have now, for each study we have kind of data management system, so we can electronically enter the data then and there, so that it will be captured there, and then whenever we want, we can download into our any softwares which we use for data analysis purpose. And then treatment allocation, drug log should be maintained from baseline, and then follow up all the case report forms, whatever the case report form you use, maybe assessing the symptoms, maybe side effects, adverse events, all this things should be missing data, adverse events, serious adverse events, all should be appropriately recorded and reported, right? So for example, in the clinical trials, it is drug-related clinical trials, whatever the AE, adverse events, or SAE, serious adverse events, normally in all the ethics, beforehand, before conducting your study, you have to have ethics clearance, ethics approval from authorized ethics committee. And if you do drug-related or device-related randomized control trial, whatever the adverse events, whatever the serious adverse event should be recorded and should be reported within. If it is serious adverse events should be reported to ethics committee and sponsors within 48 hours. If it is adverse event, within 5 days. So these are the very important data, because in the end, these are the secondary outcomes, secondary endpoints. You measure whether this drug is effective, right? And then analysis, data validation, then also, so we can't manipulate the data set at all. So there should be kind of master data set. And then from master data set, then people who is the data analyst, they can analyze the data. And then whatever the changes you do should be very well recorded and should be able to track all the manipulation you do the data set. And then reporting. Reporting should be according to consort 25 parts of the consort document or guideline you need to report, right? So as a summary, all the data you see is traceable, but important things in the data management, two main important things you have to always consider. Number one, if you are dealing with the patients, patient confidentiality should be protected. Always patient name or identifiable information should not be in the data set or any of your CRF or case report form. Should be 100% no. And then also without no any identifiable, and also when you are reporting, it should not be identifiable like patients. Also, whatever you do with the patients, very primary thing, consent. Without patient's consent, you can't do any sort of research activities. First thing, screen, consent, and then activity. And then whatever the activities you do, record, keeping is important. And whatever the data you collected should be confidentiality is protected. Also, the patient data should be protected. It is not like just widely available for anybody. No. If, of course, some extent, you need to keep their name and some personal information, that those data should be, if you are keeping in the, for example, soft copies or electronically, should be very well protected. No way of accessing by other than research group. Even if we are maintaining the hard copies, should be kept somewhere very protected, locked cabinet or something like that. So data protection is very, very important. So most of the time, if data is appropriately not protected, then researchers will be in trouble.
I'm sorry, your time is up. So you need another 2 minutes, perhaps?
Yeah, maybe 1 or 2 minutes.
Okay.
Yeah, so I will quickly wrap up. So though we are doing clinical trials, of course, this is not an easy thing. There are a lot of challenges. From beginning up to completion, you will have a lot of challenges. That is normal. So clinical trial is itself a challenge. Conducting clinical trials, you have a lot of challenges. So some of the challenges I'm going to discuss here quickly. Regulatory delays. So sometimes if it is very complex clinical trials, getting regulatory clearance from many parties, example, ethics committee, this here and there, or regulators, and some countries they have kind of new drug regulators, or maybe in Australia we call I forgot. So something like that. So all the regulation, it takes maybe 6 months to 1 year or more. And then recruitment issues, as somebody clearly mentioned earlier. It is not easy to recruit the people or patients or participate in the clinical trials. Always there's a lot of struggle. And then operational barriers. There are so many operational barriers can happen. Maybe COVID, maybe this, that, or maybe all of a sudden your device is not working. All of a sudden a patient forget to take the medication, or maybe skipping. So many operational things can happen. And funding constraints, again, is a big problem. For example, most of the time, in my experience, clinical trials may not be finished on time. Always go many years ahead. For example, if I plan a clinical trial for 5 years, it won't be finished in 5 years, but it will take another at least 2 years, right? So when you are planning your budget, you have to consider all the funding constraint. Also, all of a sudden, maybe we don't do the clinical trials with our own money, funded by sponsors or WHO or maybe government. All of a sudden, maybe WHO stopped giving money. So for our case, I was telling a study. That study, we have been receiving money for last 3 years, and then we supposed to receive that same money for another 7 years. But all of a sudden, last month, September 30th, it was the US funded study. US government said, we can't give you any more money for this study because of internal problem in the US. So all of a sudden, after recruiting 1,300 patients, we are not anymore getting that money. So we are in trouble. But we manage internally. We have some other funds and we are utilizing that fund. But it's still, if there's no any other fund, it's going to be a very big problem. And then data quality issues and then workforce limitation. These are the struggles. And then the solution, we have to come up with a streamlined way and the participant engagement, and then way of appropriately concerning participant efficiency in terms of operations and sustainable funding models, data quality assurance, and then capacity building. So these are the trials I wanted to discuss in detail, but maybe some other time. With that, thank you so much. I hope you have got something, some overview of clinical trials, right? So do we have time for any question or?
We have 5 minutes for Q&A, probably about 1 to 2 questions. That be okay? Okay. Yeah. Thank you very much, Dr. Shukry, for the passionate talk that you gave us today in regards to the clinical trial and also the consort guideline. So we will now receive questions, perhaps 1 or 2 short questions from the audience here and also from the Zoom. Okay, yep. Ada yang mau bertanya kepada Dr. Shukry terkait dengan topik yang saya sampaikan atau juga mungkin pengalaman dari yang bisa didiskusikan mungkin dari pengalaman penelitian dari teman sejawat sekalian yang relevan dengan apa yang disampaikan Dr. Shukry. Saya persilahkan, mungkin 1 atau 2 pertanyaan. Okay, maybe while we wait for our audience perhaps to raise any questions, I'm sure with us today there are many young researchers that are in the early phase on their pathway for research. What particular advice perhaps that reflecting to your past experience in regards to clinical trials or research in general that you could provide for our fellow fellow students and also colleagues that are with us today?
Yeah, I can reflect something what I have been doing from beginning of my career. Still, I'm kind of middle of my career, just passing early career research to middle career. So what I've been doing is like since beginning, while I'm working with the big research groups as a junior researcher, I try to create small studies myself and then try to get some small fundings. That way I am trying to slowly, gradually kind of do independent research, working for someone else, and then generating your own idea from your own ideas. Your own research is always a bit more challenging. That make you more sharp in your research rather than following the instruction and doing the research. So as a juniors, what I would say, like while you're working as a lecturer, as a clinician, as a researcher, research assistant, research fellow, probably you're working for a big research group or research or academically like some research institution, whatever. You try to do your own, generate your own ideas, small research, so that will mold you more than working for someone else, because you need to resolve all the issues by yourself. So by that way, you can be a good researcher in the future.
Thank you very much, Dr. Shukry, for your insight. Any other questions? Okay, hold on. So because we still have the last session that has been planned, and that is strategies for publication in Index Journal, and I'm sure a lot of us are very eager to learn more about strategies for publication. Maybe in the later days after this, Dr. Shukry can provide a Zoom recorded Zoom video that would be uploaded perhaps as an synchronized form in our learning platform. Okay, thank you very much, Dr. Shukry. Oh, sorry. So here's a question from, the anonymous attendee. Thank you for the update. So for this workshop, is there any opportunity to collaborate to do research? So how would you have any answer for that?
Yeah, so it's from online, yeah? Okay.
This is from online.
Right. So yeah, as a researcher, I'm always very happy to collaborate, do research together. All right. So the first thing in the collaboration, whoever we want to collaborate with, you need to come up with your, introduce yourself, like what sort of expertise you have, and then how that expertise can contribute to existing projects. So as mentioned earlier, I've been doing TB research, and then also antimicroresistant and then One Health related research, TB case finding, clinical trials, and then appropriate use of medication or kind of developing tools for elderly patients as part of my PhD students' work. And similar studies I've been doing last many years, like maybe 2 decades now. So I'm very happy if you have any interesting idea and those ideas are matching with us. I'm happy. Otherwise, still I'm happy to connect you with the appropriate researcher so that you can collaborate with. If that is not like my area of research or our team's research, but still if you're interested, you can contact me, and then I can either work with us or maybe I can connect with you a correct team, so who has similar research work or research ideas, so that way we can help each other.
Dr. Shukry. So connecting is one key to initiate collaboration, and from what has been mentioned to the attendee, I'm sure that the contact you would be available in the Sydney University website, right? So if anyone, pardon? Oh yeah, or contact Dr. Asri too. So that would be one approach, and a wonderful approach also, because you have those means with you. So please use those means to initiate a collaboration. So thank you very much, Dr. Shukry, for the wonderful presentation. Can we give a round of applause for Dr. Shukry? So today we had a crash course, I would say. This should have been like a almost half semester course that has been concise for all of us. So thank you so much for giving your time for us to so that we can learn more about several aspects such as clinical trial protocol that has been explained extensively through the principle of research and different phase of research, and how to identify PICO and also formulate research questions, and also the principle of the consort guideline. And we're looking forward for also the principle of a strategy for publication, and we hope that we can look up that online through a pre-recorded Zoom. So once again, thank you very much, and also applause to the audience that have interact and engaged in our in this afternoon session. I hope that everyone has had a very meaningful discussion. And once again, thank you very much, Dr. Shukry, and I will give back the floor to the MC.
Thank you so much to Dr. Dewi as moderator and also Dr. Zawahir for an insightful workshop and also discussion. So to conclude this session, we would like to present a token of appreciation to Dr. Zawahir and moderator in recognition of their valuable contributor for this workshop. So the certificate will be presented by our moderator, Dr. Dewi Suryani. So please give a warm round of applause.